All right, I see some of y'all are sharing. Um, we were on our corticosteroid slide, I believe. Also, if there are any questions, comments, you guys don't have to type. Just unmute yourself and say, hey, like, and I'll just stop. We should be done in about 30 minutes since we only have a couple of slides. With the review, because it is a Jeopardy game, I'll get with your class leader for us to discuss when I can come in on maybe a lunch and we play the game. The review should be a very thorough review. I was asked questions about Major Sternberg's reviews. I went through them. For the most part, they are good. The only issue is that I cannot guarantee that every bit of information that is on her slide or like on her what do you call it, her study sheet will be what is on the exam. My review, I will have a lot of the things that are there. So it's again optional for you guys to come. We'll decide on what day that we're going to do that. Okay. Looking at our lecture for us to finish this out really quickly. The other thing, what I'll do, there were some things that were on hers that were changed around. I'm going to print them out and then I will upload them today to Canvas with everything crossed out that we don't, that I don't want you to look at for sure. All the other stuff, it will be fine for you to look at it. Yes. I saw a raised hand. You can unmute. Okay, I'll keep going until you unmute, or you can type if you want to type in the box. So I will upload those for you all today. Right after we're done with class, I'm going to go print them, and then I'll cross out the things that I don't want you to look at for sure. And then when we do our review, we'll go over the bigger things that I want you all to go over in a game, in the Jeopardy game. All right, so our corticosteroids, you've seen this already before. Just understanding again that they are an option for us to use whenever we're talking about treating our patients here. I want you to understand when you're looking at this, we're talking about our gout flares. Okay, so what I was telling you before was remembering a flare versus your chronic suppression and paying attention to those questions that you may get on the exam or your patient. Is this a history that you have, or is this something that's new that's occurring? So when we're looking at our corticosteroids, you see that you can have your injections again, depending on where the joint is. Hopefully it's not widespread, but again, with gout, it could be. They're going to be injecting into those joints. If it's more widespread, then you're wanting to limit how many times you're doing the steroids, and looking at if it's a bigger joint, then it's better for you to do the injections versus you doing systemic treatment. So just kind of looking at that on your clinical use, that fourth bullet. So use orally if 1 to 2 joints involved, or intra-articularly if 1 to 2 large joints are involved. So that way you're not having to have a higher dose, because remember we talked about our adverse effects. You're going to see more adverse effects whenever you're giving those oral treatments. Again, IM is also available, and then you have your oral prednisone where you can do a burst, or you have the methylprednisolone, which is we call it a methylprednisolone dose pack. And it comes in a pack, and this is one of the very few times that you're able to say use as directed. Most of the time, I tell you, don't write use as directed, but on this dosing card, whenever they get their medication, they pull it out. It tells them exactly how to take it. Take one before breakfast. Take one before or after lunch. Take one before supper. Take one before bedtime. So it'll tell them exactly how they are to take this medication. So just make sure that you tell your patient to follow the package, the package insert that comes with it, like, or in the actual packaging, I guess is what I should say, not the insert. Because a lot of patients don't pay attention. They poke them all out and they'll take all 6 of them at one time sometimes. So again, just let them know there's writing on the punch out card that they're going to get, and to follow the directions there. When you're looking at your adverse effects, again, we talked about them, the systemic versus your local. Same thing that we talked about before. The higher the dose, the more likely you are to see that rebound flare occur whenever you stop. But again, it's not something that is completely avoidable. So just make sure that you're managing and that you're not using steroids if someone is having several flares. If they're having that many flares, we said after 2 that they should be put on your ULT anyway. So make sure that you're just paying attention to that. We don't want to use it too much. All right, now looking at our ULT. So anytime you're hearing ULT, you should be thinking about your chronic suppression, your patients who have had several flares. They don't want to continue to get these injections. Our typical treatment that we're using for our gout isn't working for them. This is where we're looking to go for these patients to manage them to hopefully prevent the amount of flares that they would be having. Here are our different options that we have. Do pay attention to the category that they fall under. So the big umbrella is ULT, or urate lowering therapy, but then you see that you have 3 different types: your xanthine oxidase inhibitors, your uricosuric agents, and your uricase. And then you see the agents that fall underneath them. So we're going to go over these, and you will see which ones, are our most common ones, and this is kind of in order of how you would use it. So when you're looking at this, you can put 1, 2, 3. So your XOIs first, your uricosuric agent second, and then your uricase last. Okay, looking at our indications, we've already talked about these before. So you're going to use your ULT when the patient has more than 2 of those attacks. So 2 or more. And then looking at if they have that CKD, we said stage 2 or worse, and then if they had stones. This is what we had already gone over before. Looking at our order of how we're going to use our medication, how we're going to choose our ULT, you had your XOIs first, so your xanthine oxidase inhibitors. We see a lot of allopurinol prescribed, so this will probably be one of those things that you'll definitely be prescribing when you're seeing someone that wants that chronic suppression. These can be used during a gouty attack, and this will kind of make a little bit more sense whenever we start talking about it, as long as you have that anti-inflammatory therapy with them. But it's kind of confusing. So what I want you to understand for the exam purposes is that anytime a person if they're already on urate lowering therapy, you can leave them on it. If they are not already on the ULT, then don't start it. And that's how I'm going to test you, because there are little nuances in this where some providers will start the XOI during an attack, but I want you to just, for now, don't worry about that. We are not going to start during an attack. They can continue during an attack. And then our alternatives that we have available, you see there, you have your probenecid, which is one of your uricosuric agents, and then you have your pegloticase, which is the uricase that we'll talk about, okay? All right, when we're looking at our xanthine oxidase inhibitors, we talked about this when we initially started this lecture. You see that we're trying to inhibit that xanthine oxidase because that's what increases or ultimately can increase the level of our uric acid. We said that we're already having a problem where we're not excreting that uric acid or we're making too much. So this is where we're trying to say, all right, let's shut off that inhibitor. So that is our mechanism of action, is inhibiting the xanthine oxidase. 2 meds that we have is your allopurinol and your febuxostat. Your allopurinol is the one that you're usually going to lead on. So that is, you can put a number 1 by that. We only go to febuxostat if for some reason they're not going to be able to tolerate that allopurinol. So put your number 1 by your allopurinol, because that is like our first thing that we start when we are doing ULT. All right, slide change. Okay, so when you're looking at your adverse effects or some notes or things that can happen whenever you're starting an XOI, you see that you can have those flares that occur. And this is because what essentially ends up happening is that the urate starts to, especially if they have tophi, will start to migrate out of that area, and therefore you're going to have those increased areas. So some ways that they kind of get around that is that they'll treat previously, or you will treat previously with an NSAID or the colchicine. And remember, these are some of our meds that we were using if someone was having an attack. So you're kind of going back to that prophylaxis before you would start your XOI. Looking at your dosing, not increasing that dose up to 2 to 5 weeks, making sure that you're titrating to that urate level. You're trying to get to the goal, and remember our goal will change depending on if there's tophi present or not. If they have that tophi present, then you're going to be less than 5. If the tophi was not present, we want it to be less than 6. And then looking at the fact of when you should see a change in that patient's labs. So it should take a couple of days for you to start seeing, like if you were having an upward trend on those uric acid levels, you should start to see them start to go down after a couple of days. But you'd see that you don't have that peak until about 10 days. So when you see this range of when to titrate or change the dose, that's kind of where that's coming from, is based off of the fact that I'm not going to see my peak decline or my peak performance from my medication up until 10 days. So they're saying, hey, don't change anything about this med until we at least hit that 2 to 5 week mark. And again, before you change a dose, always make sure that they are that your patient is adherent to the medication. Some of those common adverse effects, the biggest ones that you need to kind of think about when you're looking at these is that rash. So you can get Stevens-Johnson syndrome or TENS, and these are both things that you'll definitely see when we're talking about our allopurinol. And then you see some cell line things kind of happening with that leukopenia or the thrombocytopenia. CV events is another big one that can occur, especially in your patients who have prior history of that. So just pay attention to your common adverse effects, because these are big ones that can be detrimental to our patients. Looking at our 2 XOIs that we have, so you have your allopurinol and you have your febuxostat. When you look at these, just understand that, again, your number 1 is your allopurinol. So the way that you can try to remember that is A comes before F, right? So your allopurinol, you're going to want to use that all the time for your people who are always having those gout flares. So allopurinol. Looking at this and understanding kind of what they're comparing the 2, and that way you can see why we're always usually choosing our allopurinol first. Your febuxostat is one that is more expensive. It is better tolerated as well, which is why some patients are less likely to experience the side effects that we talked about when they're on the febuxostat. But when we're talking about the price, depending on where you are, that becomes an issue for some of your patients. And then looking at the fact that you have the higher risk of those thromboembolic events that could occur. So again, that's where you make that decision. Money can sometimes be an issue for some of your patients, and if they don't have a history of Stevens-Johnson syndrome or that TENS or toxic epidermal necrolysis, then you may be okay. If you start to see that a rash is presenting and they are on that allopurinol, you know what the culprit is, stop the allopurinol, and you can switch them to the febuxostat. So it is something that, again, is going to be your choice, but usually what people are picking is going to be your allopurinol right here, and then your febuxostat is usually second. All right, your uricosuric agents. When we're looking at these are something that are not sometimes as effective as our XOIs. So we will usually add these on to our XOIs if we're not getting enough response or if we're not hitting that goal. So here, your big thing and the big takeaway is that you're inhibiting that proximal tubule to kind of make sure that we're not reabsorbing the urate, so therefore our levels will decrease. You do see that they are also used sometimes in conjunction with our antibiotics, specifically looking at that probenecid. We'll see that used a lot sometimes to decrease the excretion of those. So that's kind of a unique mechanism, is that it can decrease the excretion of some of our other meds if we want them to hang around in the system for a longer period of time. But it could also be detrimental, especially if you're talking about using these with an NSAID, especially in somebody who we want them to excrete it, right? We want them to not have that accumulation or that buildup. You can see that these can make us not excrete them as much, so therefore you'll have the accumulation, more side effects. So interaction with our NSAID, especially not something that we want to see, but it could be something that's good for us when we talk about the decreasing that excretion for one of our beta lactams, which we want that antibiotic to stay around for a longer period of time. All right, our clinical uses, again, I was telling you we use this if our XOIs aren't getting us to the level that we want, our goal, or if you see that there's some reason why someone can't take an XOI, they can't tolerate it for whatever reason, just understand that is when you're going to look at your probenecid. When you're looking at your lesinurad, just understanding that this one cannot be used alone. It will always be in combo with your XOI, okay? So you would always have your allopurinol on board before you are going to add this. So probenecid can be used by itself. It can stand on its own, but the lesinurad, you would always have to use that in combination. Another thing is the dosing. So you see with your probenecid, that one you would have to take twice a day, whereas your lesinurad, you would only be taking that once a day. So just understanding the difference between the two. If you have someone who is like, I don't want to be inconvenienced, I don't want to have to take something twice a day, then you know which one you're leaning toward. Your lesinurad is having to take it less once a day. Common adverse effects, just understand that you can have the precipitation of those attacks. So just think about them giving a flare. So again, like we talked about with our XOIs, you would then be pre-treating them with one of those NSAIDs that we spoke about, or the colchicine. And usually it says 2 to 3 weeks. Most of the time we go to 3 weeks to just make sure that we're covering them so that they don't have that flare during that time. Also, you see that you can have that increase in the stone formation. So when you think about it, hold on, guys, they were here to fix the AC. Let me tell them to come in so they don't think that they can't come in. Give me 1 second. All right, sorry, I'm back. So with that, a lot of times, just to be safe and to not have that flare, it's better for you to continue it up to the 3 weeks because you don't want to precipitate the flare that's going to occur. And that's why we always caution, unless they're already on ULT, we should not be starting with ULT. You see this with the uric acid stone formation. So whenever your patient presents, if you see those stones already, this is one of the ones that we want to be careful about, because this can make them have more stones, okay? So the big thing with this, to even prevent this adverse effect from happening, they need to drink a lot of water so that they can be flushing their system out. Our interactions, lots of them. Remember, we just said before that they can keep some of our meds in, let them stay around for a longer period of time. So just kind of keep that in mind. And then looking at the salicylates, making sure that you may not see the changes that we would expect to see in the level. So don't administer this with a salicylate, specifically looking at like our aspirin, because that's our most common one that we're talking about. All right, looking at your plagoticase. So this one is an IV medication. Clearly, because it's IV, you're going to have your patient come into the clinic to be able to receive this. This is for your patients who are not getting any resolve whenever you're using any of your other combinations, okay? So if you had on one of your XOIs and then you gave them a uricosuric agent on top of it and it still wasn't working, this is where you'll add on your uricase. So that is your plagoticase, falls under your uricase class, okay? So you can write that there because I didn't put uricase on here. Your mechanism, just understand that you're, again, blocking that oxidase that's down there. So catalyzing the oxidation of your uric acid to allantoin. And then therefore, instead of it going to that staying in the uric acid form, you're still converting it, okay, to something else that's less harmful that eventually you will be able to excrete. Okay, so Already told you, your severe patients, this is one of the ones where it does require sometimes a prior auth depending on what the patient has tried. So just make sure that they are trying all of our other ULT options before you give them this, or they're a very, very severe case, meaning they have flares in several joints. They may have it also, they may have stones. Let's just make them the worst case in your brain. That's usually when you'll jump to this. But most of the time, we'll still start with other ULT prior to us doing our Plugada case. Adverse effects, again, we already said that all of our ULT, we're worried about the gout flares, but this one is a lot longer than that 2 to 5 weeks that we were talking about before. Here, you're seeing that first 3 months. So you're going to put them on that NSAID or the colchicine, which is, again, what we're typically using for our flares, for the first 6 months of them having that treatment. Unless there's some indication to them having an NSAID, which in that case you can lean on colchicine. But remember the side effects of our colchicine, so you're kind of trying to play the game to see what your patient would be able to tolerate. But this one, we're going to treat them for at least 6 months prophylactically with our colchicine or our NSAID. And then most of the time, whenever we're giving them the NSAIDs, we usually start to try to put them on the pre-medication or that treatment at least 4 weeks prior to the infusion, because the response of them having that flare is so great. And there's also the chance of them having anaphylaxis, which is another big thing that we worry about with our Plugada case, which is why it's last line. So looking at your other adverse effects, you see your infusion-related reactions, which is what I was talking to you about. So our big one, but did you die though, is that anaphylaxis. So you see we'll give them either a corticosteroid or an antihistamine prior to. Make sure that you are documenting what their adverse reaction is that they typically do have. And because they're in a clinic anyway, IV, right, IV administration, this is, that second bullet is kind of a moot point, right? Like, yes, they're going to be under your supervision. You're not going to be letting them walk away. Look at the protocol if you do administer this, because some providers will say that the patient has to stay 30 minutes after, and some providers want the patient to stay up to an hour after. So it just depends on where you are. And then your heart failure exacerbation, so watching out for your patients who have a history of heart failure. G6PD pops up. So making sure that your patients are tested for that G6PD deficiency prior to, because of the way that this medication works. This could be something that's very detrimental for them. They are coming to the clinic for this medication every 2 weeks. So keep that in mind. You would be giving them this every 2 weeks. All right. Now, this is talking about prophylaxis. What you are going to do to make sure that if you know a person has a history, right, or you see, hey, like, oh, you have TOFI, you're in a lot of pain whenever your attacks occur and we haven't been able to get you down to the correct level, you're going to want to look at some prophylaxis. So essentially, when you hear prophylaxis, think about chronic suppression sometimes as well, because we're trying to prevent them from having an attack. So essentially, just understanding here, this little chart here of when you're going to be, this is so hard to do without y'all in front of my face. Essentially what you're looking at here is, when am I going to start someone on prophylaxis? How often are they having these attacks occur? So if I'm having a gouty attack from starting treatment, so this was, if I wanted to initiate my ULT, what prophylaxis can I get? And we already talked about using our NSAID or our colchicine prior to us administering that ULT, so that we could decrease the chances of them having that flare. And then essentially what you're going to do is you're going to continue treatment until they have resolved, or until there's no signs or symptoms, there's no TOFI, their stones have gone away. And then you're going to continue this treatment until 3 months after they've reached their target goal. Or if they have TOFI, at least a minimum of 6 months of prophylaxis should be on board for them. So that's where you see this I don't know if y'all see that box, but the bottom box of where it says the duration. So you're looking at 3 months of 3 months after they've achieved their goal. If they have TOFI, a minimum of 6 months. That means that you could go longer if you chose to go longer. All right, this is the same exact thing as what you saw on the previous slide. This is just giving you words instead of a chart. In understanding our two options that we have, the colchicine or the NSAID, looking at when you're using them, okay? We've already talked about it. Just think of your prophylaxis as your pre-treatment as what you would be doing if someone had a flare. It's the same rationale going down, okay? And then you see the alternative that you have, or your second line, I guess, things that you could do would be that oral corticosteroid, but that makes sense as to why it's second line, because we don't want to use systemic steroids if we don't have to. So that's why you think that, put it in your back pocket, not something that you should have to use. All right, and then again, this is just telling you that duration. So the same thing that was in the picture, continuing until that treatment resolves. If there's no signs of symptoms, or that TOFI decreased 3 months after you hit that serum level that you were aiming for. So whether it was less than 6 or less than 5, and at this one it would be less than 6, because if they had TOFI, your goal is less than 5, and you would be doing the treatment for a minimum of 6 months. And then you see here as well, just telling you how to add. So you'll start with just one of your XOIs, which is here. And then if I'm still not getting to goal, then I can add my uricosuric agent to my XOI if I wasn't getting any resolve. On here with this losartan, your fenofibrate off-label but recommended, just remember your XOI, and then if you're not getting a resolve with your XOI, then you'll go to your uricosuric. I'm not going to ask you about the losartan and the fenofibrate off-label. And then remember, if we have refractory, we have that severe, it's not responding to anything else, then that's whenever you go to your pegloticase, okay? All right, this is looking at our what do you know. I don't know if it's going to show up. So now you guys just get all of the answers right off bat, because we don't get the little animations. So our drug of choice when we're talking about our gouty flares, we're looking at our indomethacin and your naproxen. If you are looking at your DMARDs, the mainstay of our treatment, and those were the ones that could help us modify or slow down the disease progression. Whereas when we were talking about our NSAIDs were the ones that were only helping us with the pain. And then another one, I guess, that you could put up here is your Soldenac that we had. Remember, my grandma was saying gout was a sin, right? So those were our drug of choice when we were talking about our flares. If we're talking about and you can unmute if somebody can answer me. If we're talking about our drugs of choice that we're using for our chronic suppression or our prophylaxis, what are we, for our chronic suppression, what's our first line that we would use? You can say it or type it.
Allopurinol.
Nobody? Maybe I can't hear y'all. But understanding that, yes, our XOIs, okay, would be one of our first lines that we're going to. And then looking at your gout flares may be precipitated by what class? Still looking at our ULT XOIs are a big offender. But as you saw, any of our ULTs can precipitate those flares. And then we were going to pre-treat our patients to prevent those flares with either using our colchicine or our NSAID, and our second line was us using the oral corticosteroids in those patients. All right, any questions? You can unmute, you can type, I'll look at it. And then also I will go back to my office right now. I'm gonna go ahead and print out those slides and then of the review that Colonel Sternberg had up. And then I will get with your class leader about the Jeopardy game. Again, optional. I would advise that you came to the review. But if you listened to the lectures and you paid attention to where I was saying, don't worry about this or focus on this, those are the same things that we'll kind of go over when we're looking at our Jeopardy game. Any questions? All right, thank you. Have a good day, y'all.